All right, welcome everybody. I'm Wes Warren. I'm here with Greg Stanley. We are from Whitehall Management, and today we're going to talk about probably, and I would agree with this statement. It's the great equalizer, or the great force that holds a lot of practices back from achieving their goals, either as a solo doctor, but especially if you add associates. It's what we call unexpected treatment. Greg, first of all, what's expected treatment versus unexpected, and how does it cause these kind of problems, and what can you do about it?
Well, expected treatment is kind of patient generated. Maybe a patient had pain and came in, or maybe they saw something in the mirror when they were brushing their teeth, whatever, and they kind of know something's going on, even though they don't have pain. So both of these are expected, meaning when you tell them,
They're not shocked, right?
yeah, they're not shocked, and it's even if they're a marketing patient, which they haven't gained trust in you yet, they still find that your opinion comes in line with their own, and that's expected. Unexpected is the great challenge. Whether you're an owner doctor or an associate doctor, especially associates. I know I've listened to a lot of Wes, your consultations with doctors, and one of the things you point out is that associates so often have a case acceptance or a production average of a third or less of an owner doctor.
Yeah.
And so the owner doctor, a lot of times gets the referral, returning patient. And even if there is unexpected treatment, at least there's the trust of having talked to that person before. So when the associate doctor has unexpected treatment, number one, there's a person I don't know or trust. Number two, talking about treatment I didn't think I needed. And so that can be an incredible thing to overcome. And so, I hear you talk a lot about scripts and approaches to this. We talk about bonus and trying to get our staff to pre-assess and
It's quite elaborate what we have to do to overcome unexpected treatment.
Yeah, I just want people to realize it's no small thing. And I know some people's unexpected treatment really goes almost over the top. They talk about, TMJ and things that aren't even seen in the realm of normal dentistry in patients' eyes. So,
Yeah, can I make a comment on that?
sure,
Because the
sure.
divergence is huge. And we talk about this, and certainly you have in the past, doctors that present larger treatment plans, and you really start to diverge into unexpected treatment, more unexpected treatment, and you get into TMJ, you get into occlusion, you get into sleep apnea, you get into all these different elements of dentistry that a lot of our doctors struggle with to be able to present and do well with. It boils down to just becoming almost like a disaster. If somebody doesn't come in knowing that they have headaches and they want to cure that, talking to people about TMJ, the success rate is extraordinarily low, and the alienation, you can alienate people so easily that this is we see our practices literally dive bomb with their production and everything else as soon as a doctor really gets excited about something new like this.
Yeah.
Like sleep apnea. This is something that is a problem in our office.
A lot of times the doctor is having trouble re-energizing himself or herself for this process of being a dentist, being a doctor.
Yeah.
And so they watch something, they go to something, and they get all pumped up, which is great. They're excited, and they come back to, I might say, a patient that wasn't at that meeting that kind of wants old school dentistry. And that's the problem. So let's go back a little bit.
Okay.
Let's talk about some solutions for this. Number one, be aware this is a problem. And associates, if not paired with a skilled veteran assistant, this could be a problem, a big problem. Like you said, the acceptance rate with associate doctors and marketing patients, who they're usually left with, is dismal, to say the least, not profitable. So one of the things that helps is whoever is going to be standing chairside comes in when the patient is seated and says, I notice you haven't been in 5 years. Now, don't be surprised if the doctor finds some things that you're not expecting. That goes a long way. Number one. Number two,
Okay.
she goes in the mouth with a camera. Remember, we all had to have cameras, and that there's a good reason for that. She goes in the mouth with a camera and says, you see that? You see that? You see this? You see that? And the patient goes, wow, I didn't realize the problem was that bad. Well, it is. And so when the doctor comes in, whether it's associate or owner, and reaffirms their findings, it tends to turn out better. So if you don't have an assistant who sounds confident, and she says things like, now the doctor has to decide this, but this looks to me like the kind of things he normally says need treatment. Patient says, well, what treatment? Well, a crown. What's that cost? Is that going to hurt or what not? So the doctor is being teed up for unexpected treatment.
Can we make a point here that literally before you walk in the room, you're trying to move it from unexpected to expected? Literally before the doctor walks in the room, it's been discussed, and hopefully, it's less unexpected treatment by the time you walk in the room.
There's a couple of things happening here. One is the patient's assuming that if the doctor shows you something unexpected, he or she is in a position to gain from this or to make money off of this. Whereas if a staff person finds it, points it out, shows it with the camera, less likelihood of it being seen that way. And so when the doctor finds it too, it's almost like a second opinion. And like you said, we've moved this now from unexpected to highly probable. This is going to be expected.
Right.
The patient does a lot of calculations in their head, on their feet, so to speak, where they sit and figure out what's that going to cost, what money do I have, what credit cards do I have to pay for this, especially when you point out to them that if this isn't treated, it could cost a lot of money. It could be you could lose this tooth, it could be an implant or a bridge, or etc. So make no mistake, if you're having problems with your associate, or you, the owner, feel like we were talking to you when we talk about the challenge of unexpected treatment, know that you've got to move that. If you can, you've got to move the dial from unexpected to expected before you come in the room.
I'll say that what I've learned about this, tracking statistics on this, is there's a certain dollar amount, certainly it seems like, in dentistry that a person, as they meet a new doctor, is willing to spend when it's unexpected. In other words, I came in thinking I was fairly healthy, that I didn't really need anything. I was just looking to establish in this office and get a cleaning. And when you're pointing out thousands and thousands of dollars worth of dentistry, I see a line that forms, as far as what patients are willing to accept, or they just reject you and forget about this place and try to find a new dentist. That number is somewhere right around $1,000. It can be a little more depending on the area, depending on when you're in network or not, or a little less, but it's somewhere between, let's say, $800 and $1,800. When I start to see treatment plans, certainly as phase one, get above that, it's like a cliff, as far as the numbers. It's just, okay, we're doing good, boom, it's like nothing, zeros, goose eggs. That's not to say that patients don't need it. That's not to say that they're not in desperate need of these things. That's not the argument. It's the fact that they're just not ready to accept it coming to a new office in a counter that you've put together. and present it to them. And that's just what we see nationwide. We see anomalies. Some doctors are very skilled at presenting the case and presenting their argument for why they need to do everything. They usually are in rich neighborhoods like Beverly Hills, and we certainly have offices in these kind of, and they are the ones that tend to violate these things, but we don't see it anywhere else. You're going to see a specific dollar amount that people are willing to start with when it's unexpected as they walk in the door.
Right. Let's look at what can be done. We talked about moving the dial.
Yep.
Let me add to that. When you reach out with ads, with marketing for a specific type of patient, like you mentioned TMJ and headaches, when they come in for that reason, tends to go pretty well.
Because it's expected.
Right. When we reach out to phobics with a sedation offering, same thing. They're phobics and they're kicking tires, considering coming in, that works out pretty well. We get a good sized case. They tend to have a response of, well, let's just take care of everything at once and we'll just call it good. So it can work out, but make no mistake, when a patient comes in for one thing and is shown another, and this is something I ran into when we first started working with associate doctors. Associates, a lot of times, haven't been trained that with a marketing patient, getting any treatment at all is a win. They'll show a patient 5 crowns, came in from marketing. The patient has one tooth that they're having pain with. The associate is closing hard and then reclosing and pushing to get all the work done, and they end up getting nothing. That's where I've seen this. And
I'll make a comment on that, Greg. If we were to exclude emergency patients and just look at the ones that are comprehensive, people that are coming in to establish with an office, that aren't coming in for some kind of emergency. I mean, the number of zeros in an office that struggles in this area is shocking. It's like 80% associates, 80, 90%, where virtually nobody accepts anything. And it's a number you should be familiar with, meaning you should look at your own stats, extract out the emergencies, just look at your comprehensives. How do we do? Then extract out your referrals and look at how you do with marketing patients. Remember, they're hypersensitive to this. They're the ones that really you need to start off a little slower with. And when I say slower, where you start with a tooth, you start getting something done with them. You want to look at your success rate with marketing patients. It will not be the same as referrals, but it should be within 20 or 30%.
You know, I saw a study done, I think it was by the ADA, that talked about how long it takes from a time a patient is diagnosed, in other words, probably unexpected, to getting the treatment. And it was just slightly over 2 months. In other words, they put it off, they think about it, they figure out how they can round the money up. And so what we have done is worked on the idea of trying to speed this up. One of the reasons people don't buy, no relationship with the practice. They're marketed in, shown a bunch of things they weren't expected. So we start working on the phone to build a relationship. We build on that relationship when they show up. And then we start with the assistant finding dentistry, not diagnosing, but just finding things and pointing out to the patient that the doctor might want to do something. We try to collapse that time period. And I might go one step farther. Dr. Roy Smith was famous on cases over $2,500, telling patients, he said, you just met me. This is over $2,500. I wouldn't feel at all bad if you got a second opinion. So don't feel bad. And he told me that 90% of the time patients said, no, that's fine. Go ahead. Let's do this. In other words, they saw his offering of the second opinion as a second opinion, so to speak. And so those are some ideas of how you can improve your statistics with unexpected treatment. I might add, you probably aren't going to do well with this If you have a brand new associate assisted by a brand new assistant that hasn't got any training or instruction on this, it's probably going to be pretty bad.
The other thing I'll point out on our list is what we call same-day service. By you just offering, hey, we can get that done while you're sitting here, increases the chance of them actually saying yes by 50%.
Right.
Now you have to actually be able to do it right then. But the likelihood of them doing their treatment and starting is remarkably high. 50% a staggering increase. So if you have the availability, you should utilize it. You should incentivize the team. We certainly advocate a bonus structure that gets teams motivated for more same-day service. And you should too. Definitely get your assistants, get your hygienist, everybody selling it. In other words, telling the patient, hey, you sure you don't want to get that done while you're here? And then motivating your assistants to actually wedging it in, figuring out how to, this also can be this could be a game changer in a lot of offices.
A lot of patients are amazed that they can picture themselves leaving the office with the work done instead of being prodded up the gallows staircase to the hanging, 2 weeks from now. I mean, I can just get it done now. So those are some more things that can work in your favor at offering a successful presentation of same day or unexpected treatment.
Thanks for listening, and we'll see you next week.